I like what she said about that sometimes the client's not in a good space or not able to make those calls. And I'm thinking like someone actively using who's more in line with the thought process to keep using and to get help. But she said to work collaboratively with family members. I think we can include mandators in that too as well, because I know that I worked inpatient for a while and I used to say that, and outpatient was different. I get to know a client, I'd be working with them 6, 8 months. I know their family, I know their living environment, I know everything like that. I know when I worked inpatient, we have 28 days. We get clients from all over New York State. We don't have time. So like I really worked with staff on making sure they worked with the mandators because they knew probation had been to the house and done a home visit, knew who they lived with, knew if their family was supportive or whatnot. So like while legals didn't necessarily tell us what to do, they gave us that view. So we kind of had to work out, because if we have a client that's a little resistant to being there, especially like the first couple of days, I mean, we're trying to get referrals out within the first week because we only have 28 days. They might not be in that headspace, and that's where that collaboration comes in. Once again, there have been more than 2 decades of peer-reviewed research on the ASAM criteria addressing outcomes relevant to feasibility, reliability, validity, accuracy, and effectiveness. So this is the evidence-based piece that we are supposed to be grounded in. Evidence-based also is like our own professional kind of perspective and what we've seen work in the past. So like, if you've been doing this a while, you kind of get a view of what's good, what programs are good, what's going to work, what's not going to work. So it's a combination of both. These are like guiding principles on levels of care that we need. How do the ASAM criteria apply to New York State and OASIS? In our setting specifically, the levels of care and alcohol, level of care for alcohol and drug treatment referral locator 3.0, a web-based tool that we all know and love, is built off the ASAM criteria. So the locator levels of care are from ASAM's criteria. And I would say too, because insurance companies, again, I worked in this field before locator, and at that time it was a little harder and insurance didn't want to approve anything. So kind of the ASAM criteria kind of like provided this model and framework for insurance companies to pay better, and OASIS adapted it and made the locator from it so that we could get this documented thing from the state database saying that that criteria had been met to kind of help with insurance for payment. So it's a beautiful thing. I was a pain before locator. Locators made things so much easier, and I love it. They can be a pain to fill out. I don't negate that, but we got to do it. So it's determined appropriate level of care for a client with a substance disorder and is mirrored and built off the ASAM criteria. So I already said that a little bit. What does that mean? This is how I think about it. When I'm thinking of ASAM criteria and locators, levels of care, it's like a metaphorical blanket. And when we first engage a client, and again, like in the video speaker, me too. And when I said earlier about when a person comes in outpatient, we don't really know. You know, we're seeing symptoms we always see, but we don't necessarily know if their person's going to stabilize in outpatient. So it might start in outpatient, but as we see, it's not, and it's not working. So then we kind of like grab them really tight, hold them tight all the way up, maybe like inpatient. That's like a nice big hug. And then we slowly release down into the structure, into the settings across the board. So it'd be, I'll get into a little further, but it's a step down level based on evidence. And I don't know if I said it in this training video or another one. I might have a slide later on. I mean, research shows really that like a year in structured settings is like what's needed when we're talking about like severe, I'm talking like severe cases and homelessness and all the like the worst case scenario. And even though we don't have one single place that's like you can go there for a year, it is designed that way, the way OASIS has set it up, and it's in the way New York delivers service. It's a beautiful thing, but you got to use it to make it work. And so it might not be like we can send a client here for a year to live, but we can, through the continuum care, give that, whether inpatient, followed by the 820 intensive residential levels, followed by halfway house, followed by supported living. That's that year right there. And it's a step down to where the client is at as we're working down them. And if a client has a slip, we might pull little clients in community residence and has a slip. I mean, outpatient might want to work with a little bit more first, but say they need to go back up to intensive residential because they're not like running out and straight back to the use, the intensity and frequency they were at, but they are kind of having a little trouble. You know, it's more than just a bump, like they're kind of relapsed full blown. Then they'll go up a step. Or if it's like they go out running and then we re-engage through outpatient and start at inpatient and work again down. So that's how it works. It's that hug, and we kind of release as we go using the client's behavior, the client's buy-in, collaborative care with the family members, mandators, family core, treatment core, and whoever. And kind of the evidence-based part is the ASAM criteria in our experience on what knows work in that metaphorical blanket. Does that make sense? It is rarely a linear and straightforward progress. We must be watching and ready to tighten that blanket up anytime the client regresses, relapses, or even needs to be re-engaged in treatment. Client has full-blown relapse and goes out and goes MIA for a couple months. We're going to send some community teams, peers, whatever it can be to try to re-engage that client. As ASAM criteria is evidence-based and designed to follow natural progression of order, as the client becomes stable and is ready to move to the next step, for example, starting an inpatient, the most empirically supported is the ASAM level 3.5 high intensity residential first services, and that would be stabilization, rehabilitation, 820 in New York. ASAM levels translated to locator, ASAM level 4, detox. Medical detox is the first part of the rehabilitation process. Recover from addiction is often followed with some kind of behavioral therapy, medication, continued support. Detox can be defined as the process of clearing toxins from the body of a patient who is dependent on substance abuse. It is designed to manage the symptoms of withdrawal that follow cessation to help patients overcome physical dependencies. So the criteria for detox is one thing alone. The person is using substances with risk of medical complications from withdrawal. So we would typically only see that with opiates, alcohol, and benzos. Those are like the three things that clients will detox from. All the other substances do not have the physically withdrawal symptoms, so therefore it would be inpatient. That would be their level. But for those three substances that they're using and they need to detox, then they start at level 4 or detox in New York State. Level 3.7, inpatient. During inpatient treatment, clients are surrounded by support and services, quality inpatient facilities. Clients safely detox from the substance they're addicted to, and that could be detox to meth or cocaine. I mean, because there is a psychological dependency, but not so much. So still getting that stability, neurons reconnecting, brain healing, that kind of thing. And next, they transition to an individual counseling session, group therapy, or other treatment service. They live in a safe environment, have access to nurse and other health professionals. And that's what I was saying. I mean, inpatient facility, I just said that I worked at before. We are 24/7 medical staff. We have to have RN on 24/7, 7 days a week, 24 hours a day, 7 days a week. There is an RN on, doctor on call, provider on call, not always doctor, nurse practitioner, but either way. Criteria for inpatient, it only takes one of the three needed below. So again, it could be all three, but it only takes one. The most common is the use in hazardous situation. Amounts frequencies like to imminently cause severe physical or emotional harm yourself to others. That is the most common criteria for inpatient. I mean, these other ones might play a role, but what we're seeing, and that's when we're seeing 2 bundle of heroin a day user, 200 hours worth of crack cocaine a day, like very intense and severe levels of use, and no ability or intention to stop outside of a structured environment. So that one criteria is all you need for inpatient services. However, if a client also has serious medical symptoms that need managed inpatient, so if client diabetic maybe or an unmedicated, maybe we'll get them there to medically, because it is a medical setting, and to get them stable on meds and then transition down to the next level once some symptoms are managed. And same with mental health. That's the third one. Serious psychiatric symptoms that need to be managed in inpatient rehab setting for SUD treatment to be effective. So again, that's what it's really about. It's about stability and getting the uses like at a level that causes harm, imminent physical risk, and also medical and psychiatric symptoms. But again, only one needs to be met. If all three are met, they definitely need to go. But if one is met, that's the criteria for inpatient in New York State. And like number one, the use in hazardous situations usually is the one. ASAM level 3.5, clinically managed high intensity residential service. In New York State, this applies to both stabilization and rehabilitation residential services. So for both levels, stabilization and rehabilitation, they have these three in common. And just like inpatient, only one needs to be met. If three are met, they still need to, that's even more of an indicator they should probably be there. But again, they just need one. And it would be an inability to establish and maintain stable employment, and an ability to establish and maintain stable relationships. So they got a history of able to keep a job, always getting fired, quitting because due to their use, or just constant interpersonal social problems, and they have a history of maintaining stable relationships. Third one is persistent regard for social norms, rules, and obligations. For example, a history of repeated arrests or involvement in criminal justice system. If it is that one, though, too, the locator will also then take you if they exhibit predatory behaviors, and then they will not be going there. So if they do have a history of violence like that, I know I was really about getting people in, but I remember one time a guy, he was diagnosed antisocial personality disorder, history of violence, and he was unmedicated schizophrenic too. So I think he was experiencing psychosis, and definitely we denied that one because And that was at inpatient, so definitely not for them. Usually the locator will say psychiatric hospital, which we don't really have, but that is what it'll spit out. All right, so back to this. Sorry about that. I got a little sidetracked. Stabilization and rehabilitation services. This is the 820 that we have in Dansville. This is the 820 that CARES has in Olean, CARS in Trumansburg. And actually, let me pause there before we go into this further. So CARS made me think about it. I know when Oasis changed the names, I don't know, a couple years ago now, 2-3 years ago, to stabilization and rehabilitation, because it used to just be intensive residential. It is that level of care. It is intensive residential. While no one's ever came and said it to me, I speculate because I remember like a year or two before they made those changes. First off, there wasn't a lot of them. There was, off the top of my head, I know CARS was around in Trumansburg, and I know that Liberty Manor and Freedom House in Rochester were around. They were intensive residential. And there was others, but I'm just using these ones as an example. There wasn't a lot like there is today. And I remember a year or two, if I had a client that went to one of those programs, I mean, before previous, like they could be there 3 to 6 months and no issue. A year or two before Oasis changed the names, insurances started getting real, like, strict with it and kind of making everybody trying to discharge at 60 days and saying that that's all they need, because they were probably using the ASAM criteria. And I don't know, I'm just going off the top of my head here, but say that like for that medically managed part of the high intensity, maybe they were saying insurance is saying 60 days is all the most that's needed for that. So that's why, I don't know why they got really hard all of a sudden, but my guess is that. So then I think, then it's my opinion that Oasis then split that into 2 levels so that we could provide that continuum care without as much barriers through funding, if that makes sense. I hope so. So as a result of that, you got this. And these are the 3 things that would determine if a person meets that 820 level of care. However, for stabilization specifically, it needs one of the following as well. So if a client has any of these 3, they're good for rehabilitation basically. But if they include either a strong craving or urges that are unmanageable or behavioral emotional instability, then they would meet criteria for stabilization services. Does that make sense? So stabilization and rehabilitation both have this, they both have, oh, a little better at that. They both have these in common. But then for stabilization, it would also include one of these. And just like up here, only one needs to be met, same for stabilization. So if a person has an inability to establish and maintain lots of social personal relationship, inability to maintain relationships, and they meet criteria for 820, and on top of it are behavioral or emotionally unstable, so maybe unmedicated bipolar or need a medicated adjustment with bipolar, so mood swings, then they would meet criteria for stabilization. If they did not have that, nor did they have a strong craving or urges that are unmanageable, then they would just meet criteria just for rehabilitation. Does that make sense? So flip it around. Client has persistent disregard for social norms, rules, and obligations, and a history of repeated arrest and involvement in criminal justice system. And that's a lot of our clients, that one right there. I mean, come on, legals are probably our #1 referral source. And almost all our clients have a history. It's a little bit different. Client has 1 arrest and conviction, then a client has been to prison twice and currently has a charge pending. So that one would make them criteria for the 820 intensive residential thing. But then on top of it, if they had strong cravings or urges to use that are unmanageable. I want to talk about that too briefly, because I think that is the difference between what gets mixed up with the new 820s. So for a person to go to stabilization service with the strong cravings or urges to use that are unmanageable, it does not say that that means you specifically, but I think it does strongly imply. But I think the difference would be that would, so for the inpatient criteria, let's go, if we can find that one back. Use in hazardous situations. So like use that is definitely going to lead to arrest or death or harm to the person if they're shooting meth and having psychotic episodes kind of thing, you know what I mean? So when it's on that level, whether, you know, like it's a high intensity level, then it's inpatient. I think that even though it doesn't specifically say for stabilizations, it doesn't say use as part of, but I think if the strong cravings or urges that are unmanageable, that would suggest they were using, but I think that also goes to maybe, I don't know, drinking excessively, but not at a level that would need detox. So maybe Thursday through Sunday binge drinking or sniffing cocaine on the weekends kind of thing. You get what you see the difference that I'm saying? And not that it's good to sniff cocaine on the weekends, but that's a lot different than someone who's smoking 200 hours worth of crack daily, or shooting 2 bundles a day, or doing a half a gram of meth. You see the difference there? So it would definitely be close to inpatient, but inpatient would be at much more higher. They're showing the symptoms at a much higher level and a much more level that's going to cause harm. So I think that it'd be wise that if we're following the ASAM career as a step down, it'd be in a perfect world, it would always come from inpatient. But I do know that in that collaborative and negotiation with clients, it might be easier to sell one of these 820s. But I do think we need to be mindful of if that's going to be the good fit for the client. If we got a person who's injecting meth daily and having meth-induced psychosis, starting them at that level of care is not only not good for him, but it's also not good for anybody in that program, because that's not the place that they need to get that initial ground for. No, does that make sense? So before we move on, 820 services are one of these three: inability to maintain in stable employment, inability to establish and maintain stable relationships, and persistent disregard for social norms, rules, and obligations. So like a long history, criminal history. And then that's just for the 820 level period. If one of those three is also accompanied by strong cravings or urges that are unmanageable, or it could be both, behavior, emotional instability, then they meet criteria for stabilization services. And realistically, I think any client we're probably referring to this level of care probably needs to start stabilization, because just like the strong cravings or urges to use that are unmanageable doesn't necessarily mean they're using, and doesn't also mean they're not using. It doesn't necessarily mean they are using. So maybe they haven't used for a week or two, but they're having a lot of trouble around it, and we're trying to get them in there for that. So I think it's a fit in both areas there. ASAM level 3.5, clinically managed high intensity. This is stabilization specifically. As a metaphorical blanket, starting from inpatient, the next step would be this, and then residential. Should always be considered the gold standard providing effective quality care. And again, the gold standard and what the empirical research shows. But I think when we're treatment planning, especially person-centered treatment planning, I mean, if you haven't took the person-centered planning training I already did, I'll just give a quick highlight. Person-centered plan doesn't mean that we just co-sign anything the client might want to do or say, because if we're dealing with early recovery and active use, that's just going to lead back to use. So there is like some ethical obligations we have, and some obligations we have not to be neglectful in our care, but it is also a collaborative effort and negotiation and compromise. So that's why I said it should be the gold standard. So I think when you're doing that person-centered plan and working with the client, even if that is not achievable, that some rendition of that, or they can offer that kind of level of support, should be the compromise. So say you're trying to get someone inpatient, they're like, no, I ain't doing that. They're fine with going to an 820 stabilization. Maybe you tell them we need to see a week of no use, or like severely reduced use to make that call. They agree and they do it. That's kind of the compromise area. But the gold standard would always be using no step downs. Stabilization high intensive residential means client will benefit from 24-hour supervised setting, successfully maintain abstinence, participate in treatment, because that's the thing at the 820s, the stable and rehabilitation services are in-house, and achieve lasting recovery in a more independent setting. Service provided within the facility include medical and psychiatric care, nursing services, vocational services, and clinical groups. Criteria for stabilization, I already went over with that, so it's the same as rehabilitation, but also includes the urges and the cravings and physical or emotionally unstable. The medium rehabilitation services, I mean, we already went into this, but client would benefit from 24-hour supervised setting, successfully maintain abstinent, participate in treatment, achieve lasting recovery, more independent setting. Service provided within the facility include medical and psychiatric, so very similar to stabilization. I know that, like, some examples I can give is when someone's in stabilization, they might not go out to the community as much, or 10 AA or NA like that, but get 3 hours and 5-hour passes. In the 820s, they don't usually do weekends or day passes like the halfway houses will, but they do get 3 and 5 hours, but that is not something they would get in stabilization. However, with step downs for rehabilitation, they would. So it's like that blanket's getting a little loose, even though it's in-house still. Same criteria I went over, so it's the same as the stabilization, but it's minus the cravings or the emotional instability. And again, the 3 criteria for 820's period is establish and maintain employment, establish and maintain relationships, and persistent disregard for laws and social norms demonstrated by a long history of arrest or criminal involvement. 3.1, reintegration in New York State. I think I messed up there because I don't think it's called 3.1 in ASAM, but either way, you guys watched the video and we already went through it. So reintegration in New York has two levels: community residence and supported living. I'm also going to tell you, like, community residence. I know in my experience, while there's some I can think of, and I'm not going to bash any, that would take off the streets in active use, and that's not the norm. Usually if we're referring to halfway house, they want some like period of abstinence. So like coming from an outpatient, that would really be like maybe the person's got like 30 days, hasn't used, but there's become homeless, or they're in a environment, so early in recovery still, but in an environment not conducive to recovery, and they might take a halfway house, but typically they try to take from the 820s. Again, that goes across the board too. There are some even supported livings that might take from an inpatient, but typically a supported living room is no way, no how going to retake it from an inpatient. Same thing with a halfway house. They're going to want 820 first, a lot of them. You know what I mean? So for community residents, client is currently living in or will be discharged from rehabilitation residential to an environment not conducive to recovery in a 24-hour supervised setting, because community residence is 24-hour staffed, not medically staffed. That was low intensity. She talked about low intensity residential. Clinical services, they might do a group or two or have AAN or a day during the week, but clinical services are usually done in an outpatient setting when a person's living in community residence. Excuse me. However, it's 24-hour staff, so there'll be an overnight, someone there all the time for them. When they get there, usually a small blackout period, but they also get like weekend passes, they get day passes, depending on where they're at. Some do not allow working, some of the community residents to maintain employment, but I know I worked at Wider House, and if someone was getting like, maybe they were getting close to the end, they were going supportive, like even when they were still in the halfway house, they would go out and get the job and start working, and then once it was kind of stuff that's program based. Some will allow it, some will not. I think East House and Rochester, if you lived in the halfway house, you couldn't work, but that might have changed as well. It's been years. And then step down after community residence supported living. And this is basically apartment programs. Sometimes they're staffed like 8 to 5, sometimes not staffed at all. They just check in. They're like, usually a place will either own a house, they rent out the rooms and they call it supported living, or maybe a place will have a contract with like an apartment complex and they will live in the community amongst people in that building are going to be not diagnosed with substance abuse. They're going to be families and whatnot. And like maybe 2 guys or 2 women will share a house or apartment, like it's a 2-bedroom, and that would be a supported living program. And that usually almost always comes, they definitely want a period of absence before that with verification. So typically from an inpatient or not, they wouldn't take, or I don't think they would take from 820. They want from a halfway house. Funding. Well, in a perfect world, funding would